There we go.
Can y'all give me 2
All right.
seconds? I'm sorry.
You're good.
And what chapter is it? 16?
Oh, look at that. I'm prepared. Hold up. I think it's 16. I actually have the
I'm
book.
sorry. It's the endocrine system, right?
Endocrine, yes, ma'am.
Okay, I'm sorry. Yeah,
Right.
I'm mommy and teacher, everything today. I'm sorry.
Oh, bless your heart. Yes, starting in chapter 16, and then it goes into a little bit of 17 because that's I think that's diabetic meds.
If it's endocrine, this one it says week 10 urinary medications and vaccinations.
Yeah.
Huh?
Oh, thank you.
Oh shit.
It's supposed to be drug therapy for central nervous.
There we go.
Yeah.
There we go. Alrighty.
Okay.
Here we go. Guys, just let me know if you need me to pause it or stop it or anything, and we'll do just like we did yesterday. Okay.
Ms. Duhon?
Uh-huh.
I was going to ask, which chapter are we in? Because I'm looking at chapter 13.
Say it
This
again.
is
You're
just week 13. It's not chapter 13, it's week 13.
We're in chapter.
Okay, but I was looking for the chapter in the
16.
book. Chapter 16. Okay, thank you.
Uh-huh.
Hello, guys. This is your endocrine medication lecture.
Is this
for
too slow?
pharmacology. Just a reminder, you guys
Yes,
will
that's
have
too
the
slow.
ATI test-taking seminar on December the 9th between the hours of 1 and 5 with Miss Jackie. All right, so let's review the endocrine system again. Endocrine system, in conjunction with the neurologic system,
Is that okay?
works to regulate and coordinate body systems. It works to control and maintain homeostasis. It does have endocrine glands and a few exocrine glands, like the pancreas acts as both, and the liver acts as an exocrine gland. But the endocrine glands that we discussed in A&P are your pituitary, your thyroid, your parathyroid, your adrenals, your pancreas, the testes, ovaries, the placenta. We also talked a little bit about the thymus, even though there's really no medications for the thymus, as well as the pineal body or pineal gland, but there's really no medication. You could take that unless you just take supplemental melatonin. Okay, in thyroid disorders, as discussed yesterday, you have either hypo or hyper secretion. So let's talk first about the thyroid. In hypothyroidism, you have an underactive thyroid. And if you remember, the hormones that are secreted from the thyroid are going to be T3, T4, and calcitonin. So when you have hypothyroidism, everything in the body is sluggish. The metabolism is sluggish, which means everything is going to slow down. The patient's going to be weak. They're going to be lethargic, always sleepy. They're going to gain weight. They're going to be depressed. They may be hypotensive. They may be bradypnea, where they're going to have slow heart rates. They're going to be bradycardic, where the heart rate is going to slow. They're going to be, bradypnea, where the respirations are going to be slow. They will also have intolerances to cold, so they really can't deal with cold environments. On the inverse, you have hyperthyroidism, which everything is the opposite. They have an overactive thyroid, so they're going to lose weight. They're going to still want to eat, so they're going to eat quite a bit, but they're going to continuously lose weight. They may have they will probably have some anxiety. They're going to be wired, excited. They're going to be hypertensive. They're going to be tachypnic, so the heart rate is, the respirations are going to be high. They're going to be tachycardic because the heart rate is going to be high. Everything is going to be wired. They'll be insomniacs. They're not going to be able to sleep. And they also cannot tolerate heat. So let's talk about medications that we use to replace the thyroid. The most common one that we use is going to be levothyroxine or Synthroid that we give our patients. And what it does is that it increases the tissue oxygen consumption. It's going to increase body temperature. It can cause tremors because it's starting to raise everything and make that person a little on the wired side. It's also going to increase heart rate, respiratory rate, and cardiac output. and it improves the overall mood. It improves the overall mood for your patients. Okay, so it's utilized to replace T3, T4, and calcitonin levels because at that point the thyroid is lacking. So let's talk about some adverse reactions that could occur. Okay. Adverse reactions of these medications are going to be very similar and indicative to hyperthyroidism because that's can be what it creates. So in high doses, especially in higher doses, you will see tachypnea. So they'll have rapid respirations. Their blood pressure can go up. Their heart rate can go up. They can have hand tremors and start shaking. They can have some insomnia and some nervousness, They can have diarrhea and vomiting. They may experience weight loss now, hyperglycemia, high cholesterol levels. Everything is elevated. A weight loss. They're going to have an increased appetite. And despite having that increased appetite, they're still going to lose weight. And they can have an increased body temperature. So everything with these medications are going to somewhat mirror hyperthyroidism. Okay, so your role when administering thyroid medications, thyroid replacement medications, they must take it early in the morning. Normally, we advise them to have it at the bedside. So as soon as they wake up in the morning with a little cup of, with a bottle of water, please go in and have some water and try to take it with a full glass of water, but take it early in the morning as soon as they wake up. That's because it makes you wired, right? It's going to change your mood, improve your mood. Heart rate's going to go up. You're going to be anxious. So make sure that they take it early in the morning. Also, very importantly, do not stop hormone medication abruptly. Unfortunately, it can drop the thyroid levels and create, a theoretical, not theoretical, but a hypothyroid situation, which can be really life-threatening. So you definitely do not want to stop it abruptly because it'll drop that heart rate, drop that blood pressure immensely. Also advise them to never, ever skip a dose. It's very important that they take their thyroid. It's like life. They have to take it, and chances are they're going to be on it for the rest of their life. So they cannot skip a dose. The same thing could apply. They could have rebound issues going on and ultimately drop that blood pressure, drop the blood sugar, all of those things. Okay. If they are taking with warfarin, the blood thinner, it can increase the effectiveness of warfarin, making them more exposed or disposed to any blood thinning. So they might be having a lot of bruising, a lot of bleeding. So just make sure that they're doing everything that we said about warfarin, monitoring their warfarin levels very, very closely, using soft bristle brushes. Do not shave with a straight edge. You must shave with an electric razor. And of course, have their warfarin levels checked. May even have to have it checked a little bit more frequently. Also, do inform patients of side effects to expect. So if the dose is too high, they're going to see that increase in heat intolerance. They're going to be burning up constantly. They may see increase in weight loss. They may have some tremors going on, jitteriness, restlessness, insomnia. That can occur if the dose is too high, and to call you or their healthcare provider immediately so that the dose can possibly be tweaked a little bit, can be lowered, okay? Alrighty. Also, we do have medications that if the patient has an overactive thyroid that can control thyroid. These are called anti-thyroid medications. Okay, so with these, ladies and gents, oops, I'm sorry, I'm trying to something down here. Okay, with these ladies, I'd like to discuss adrenal gland
What happened?
hyperfunction rather, and we utilize
Oh no. Oh,
potassium
sorry,
levels in
guys.
patients. So
Did that skip for everybody else? Okay. Hold up. I'm gonna stop sharing for just a second. Go look at this. Anti-thyroid is what she was talking about. I wonder what happened. All right, let's see. Full screen go, share my screen. Go here. All right, so anti-thyroid products, they're there for stopping the production of thyroid hormones. And these are used to treat hyperthyroidism or to improve hyperthyroidism in preparation for surgery or radioactive iodine therapy. With these anti-thyroid products, you will have as an adverse reaction, low vital signs and weight gain. So basically the opposite of your thyroid product. So if you're taking these anti-thyroid products, then you have to be on the lookout for those signs of hypothyroidism. So everything's low, weight gain, even if you're not eating that much, the same things that happen with hypothyroidism, okay? Your nursing implications and patient teaching. Be sure to avoid activities that increase the chance of bleeding. So like she said earlier, you can't use a straight razor when you're shaving. And by straight razor, I mean something like a disposable razor, something with those blades just right out there waiting to cut you. You have to use electric shavers, okay? This can take up to 2 weeks to work. So you should always let your patients know you're not gonna see immediate effects of this medication. So, please be patient. Don't take it for 2 days and realize it's not working. It has to build up in your system first. So please be sure to tell your patients that it's going to take up to 2 weeks for it to work, right? And then that they'll need to watch out for signs and symptoms of liver toxicity. All right, so we want to make sure we're monitoring those all those liver enzymes to ensure that they're within normal range. All right. Monitor their clotting, monitor their skin. Those signs of liver toxicity, they may have jaundiced skin if they're becoming toxic. Coffee colored urine, even clay colored stools. Those are all symptoms of liver problems. So always tell your patients to look out for those things. All right. Any questions on the anti-thyroid products? Very good. Hold up. We'll go back to where we were.
Did she say the name of that was Synthroid? I thought I heard her say that, but I was kind of like.
Synthroid is a thyroid product. That one is for hypothyroidism. That's when you don't have enough of your thyroid hormones. All right. Just
Excuse me.
all right, now I'm gonna push play, taking you back to Dr. Ross now.
The patients are having, ladies and gents. Oops, I'm sorry, I'm trying to something done here. Okay, with these ladies, I'd like to discuss adrenal gland hyperfunction rather, and we utilize this to reduce potassium levels in patients. So if the patients are having, hyperkalemic situations, perhaps with kidney issues, even with adrenal issues, then yeah, we're going to go ahead and because potassium levels are going to back up, so we'll utilize these for that. Okay, so, excuse me. So side effects are going to include nausea and vomiting, skin rashes, and then sometimes.
I think it skipped more than just that one.
Make sure you're educated.
She skipped like 7 slides or 4 or 5 slides, something like that.
Oh no. Hold on.
No, she only skipped that last slide on page 2 because it's the next one on page 3.
No, it's not. That's hypofunction. This
Yeah.
is hyper.
Yeah, I see it skipped as hypofunction is skipped. So we'll hold up. Let me go back over here. It said hypofunction. Alrighty. You guys see my screen okay? Oh, hold up. There we go. All right, so adrenal gland hypofunction. Remember that your adrenal gland from yesterday, it is for manufacturing glucocorticoids, mineral corticoids, and small amounts of sex hormones. Right. So your medications for adrenal gland hypofunction are for adrenal insufficiency, aka Addison's disease. And guys, don't worry if you're not too, I guess, caught up on these disease processes. You'll learn them more in depth when you get to med-surg, right? But these drugs are also used to reduce inflammation in allergic or immunologic responses. They'll treat hematologic and malignant diseases, and they're also good for rheumatoid arthritis. All right. Make sure she didn't have any other notes here. All right. So with your adrenal gland hypofunction, for those medications, hold on. All right. Just remember that the drug interactions there, they will increase the effects of barbiturates, sedatives, narcotics, and certain anticoagulants. So you need to be very careful about giving them in those instances. And they will decrease the effects of insulin, oral hypoglycemics. So with both of those, you want to make sure that you're increasing the amount or the times that you're checking blood sugars to ensure that the medications are working. But it'll also decrease the effects of Coumadin, isoniazid, aspirin, and some broad spectrum antibiotics, right? Some side effects can be bone loss and prednisone. So I would imagine if you're taking, oh, excuse me, bone loss is the side effect, not prednisone. Sorry about that. So
Add calcium to the diet.
yes, you're going to add calcium to the diet. Very good. Very good. So examples of this medication would be prednisone. And have you guys talked about prednisone before, or is that all new today?
We talked about prednisone.
Okay, very good. So that is an example of one of the medications that can be used for adrenal gland hypofunction. Right? So
We didn't talk about it too much in depth though.
oh, very good. I am certain that there is, and forgive me, I am certain that it is somewhere in this book.
Right.
Listen, sorry guys. But so for your nursing implications and patient teaching, your patients need to be frequently monitored, all right? They need to have their blood glucose checked frequently. So I don't know if you know anyone who's diabetic, or if you yourself are diabetic, if you've ever had to take a dose of steroids, it can throw your blood sugar off. And that's whether you're diabetic or not, really and truly. So me just walking in and having to take steroids such as prednisone, if I were to go to the doctor and they were to draw my, if they're going to check my blood glucose, I would have to tell them, hey, I'm taking prednisone, so my blood glucose level might be a little elevated, more so than it normally would be. All right. So that's one thing that you would always want to say if your patient is taking something like that, that if they're having their blood sugar checked, to let whoever's checking it know that, hey, I'm taking this medication and it may elevate my blood glucose. And they'll probably just check it. If it's super high, they'll probably have them come back and monitor again once the medication regimen is completed. With these meds, you also want to stop smoking or avoid smoking. Don't do the alcohol because you could get an ulcer, all right? For medications such as prednisone, there is an increased risk for infection, all right? So don't go and get any immunizations, especially live viruses, because your immune system is going to be low due to taking this medication. So don't do that because you have a higher risk for infection. Don't abruptly stop taking them, right? It'll make you you won't feel right. You'll have like your body will be all over the place, basically. You may have mood swings, you may have, certain, hold up. I'm in your book right now just to make sure I'm not telling you incorrectly, but these are the things that I know happen when you take prednisone and then you don't take it. You just stop taking it like you're not supposed to. You can get GI upset from it. So make sure you tell your patient, do not abruptly stop taking this medication. Most times when they're prescribed drugs like prednisone, they will give you the medication in a way that it tapers off before you stop taking it. So if you're taking 1 milligram, then before you're done taking it, once the course is completed, you'll taper down to a 0.5 milligram. They may take you down to 0.25 milligrams, and then you'll be finished with your prednisone regimen. So tell your patients, please take all of your medication as prescribed, just like with your antibiotics, right? If there's times of stress, if someone's acutely ill, you want to make sure the dose is increased. And of course, the doctor will do that. You guys don't have to worry about it. You just give the medication, right? These medications can increase your hunger and appetite. So you'll notice if your patient is taking prednisone, or if you ever have to take it, you're going to eat a lot, all right? And of course, that could have something to do with your blood glucose increasing, right? It could be hand in hand. But you will have an increased appetite. You will get a little hungrier. You might gain a little weight. Not a fan of taking the prednisone, guys. Mood swings, hungry all the time. It's not fun times, okay? And most importantly, do not crush your prednisone. If you're giving it to your patient, if your patient is a G-tube person, it is not to be crushed. So do not crush it. Your doctor or the pharmacist can come up with a different formulation so that it can be given. So I'm pretty sure it comes in I don't know if it's a suspension or if it's a straight up liquid form, but do not crush it. There's another way to give it, or there's another formulation of the medication to be given if it needs to be taken another way than pill form, all right? Like I said, make sure that your patients are checking their blood sugar frequently. Do not give to patients with diabetes. Don't give it to patient with diabetes, but if it is prescribed for someone with diabetes, know that you're going to be more frequently monitoring their blood glucose levels. Okay. Scroll to next. All right. Make sure your patient knows the signs and symptoms of adrenal insufficiency. If anybody is in your book, if you want to tell us what those signs and symptoms of adrenal insufficiency are, that'd be great. Nobody? Hypoglycemia, salt wasting, hypotension, weakness, and high blood potassium levels. That's not good, right? You get high potassium levels, what's that going to do?
Mess with your heart.
That's right. It's going to mess with your heart. Very good. We don't need anything messing with our heart. So let your patients know those. They'll probably be monitoring those patients' lab values very closely. Have your patient put on a medic alert bracelet if they're going to be on this medication for a long period of time. So that if there is an emergency, then the emergency officials who show up to help them will understand what might be going on a little bit better, and they can plan their care accordingly. All right.
Ms. Duhon, what was the other one? It was hypotension, hypoglycemia, and what else?
High blood potassium levels.
There was another one though.
Salt wasting.
Yes, thank you.
Uh-huh. All right. Let's see. We already said don't stop abruptly. Let's see here. Immunization considerations, I already told you. Don't get any, just don't get any. But if you're gonna get some, don't get any of the live viruses like the varicella vaccine, the MMR. because your immune system is not as great on these medications as it could be. These medications will cause immunosuppression, right? Diet. Right, with high doses, watch for compression fractures, right? So if your patient comes in and they've been walking around, skipping around, and they've got pain in their foot or pain in their ankle, you may want to see if they're on any glucocorticoids because they may have a compression fracture. That may be what's causing their pain, right? And do not give to patients with diabetes. We'll go with that. All right, here we go. We're gonna take it back to Ross. Y'all pray it don't skip ahead no more. Thank you, Ms. Brockers. Yes, that is correct. Page 292 in the farm book. Ooh, I skipped ahead. I was on 298, unless you said that a while ago. Okay. All righty.
Down here. Okay, with these ladies, I'd like to discuss adrenal gland hyperfunction rather, and we utilize this to reduce potassium.
Hold on, guys. I forgot to switch my screen back so you guys can see.
Sorry, I'm trying to something down here. Okay, with these ladies, I'd like to discuss adrenal gland hyperfunction rather, and we utilize this to reduce potassium levels in patients. So if the patients are having, hyperkalemic situations, perhaps with kidney issues, even with adrenal issues, then yeah, we're going to go ahead and because potassium levels are going to back up, so we'll utilize these for that. Okay, so, excuse me. So side effects are going to include nausea and vomiting, skin rashes, and then sometimes it can be adrenal issues, adrenal insufficiencies. Make sure you're educating your patients to keep all of their appointments and lab works, especially because it has a tendency of modifying sodium and potassium levels. If they immediately, to notify you guys rather immediately, if they develop like salt cravings or muscle weaknesses or any kind of hypotension, low blood glucose, headaches, problems concentrating, or shakiness, to notify the healthcare provider immediately. Okay. Now let's talk a little bit about sex hormones, and they are influenced by the anterior pituitary. So if you remember, it was the luteinizing hormone, and
Is there anything playing?
I'm having a total brain fart.
Oh, hold up. Can y'all not hear it?
I can.
Oh. What was the last thing you heard, Miss Cindy? You go back a little bit. I paused it for now. Do you want me to rewind a little bit, Ms. Chubb?
I don't know if she can hear at all.
Oh,
I can hear you.
I can hear you.
you can hear me?
Yeah.
Okay.
Well, I can hear Dr. Ross as well.
Maybe it's her internet.
No, I was saying that I was telling Cindy we couldn't hear her.
There is a neuromedicine
What just
pharmacology
happened?
for you. Let's move on.
Oh, what happened?
I'm going to cover the medications that affect the central.
Is anybody else playing the video? Because I'm not playing it right now.
Yeah, we'll cover a few things. Also, we'll talk a little bit about some
I
medications.
heard the video.
I can hear the video.
I can too. I'm not playing it.
Oh my
That's
God,
weird.
it's creepy.
Yeah.
It's going to include everything.
Hold on. I don't know what's going on here. Mine has been paused since Miss Chubb said that she couldn't hear it, so I haven't been playing anything. I don't know what's going on here. All right, let's see. Okay, let's try this again.
Hormone.
Can you hear that, Miss
And
Chubb? Okay.
oh, I'm having a total brain fart there, but it was luteinizing hormone and follicle stimulating hormone that's going to help regulate with hormonal balances. So for ladies, it's going to be estrogen and progesterone, and for males, it'll be testosterone and a few other androgens, but mostly it's going to be testosterone. So let's talk about when those levels in ladies are low. Normally is going to occur maybe late 50s or so, mid to late 50s, where they may develop menopause. And menopause is the cessation of menstruation as well as ovulation. At that time, the woman has a significant decrease in estrogen. And remember, you need estrogen in place in order to have ovulation as well as the start of the start of a menstruation. So during menopause, patients are going to develop dry and itchy skin. They may have dry vaginal membranes. They start developing hot flashes, moodiness, insomnia, real bad insomnia, and then difficulty concentrating, difficulty remembering things. So the way that we replace these hormones in menopause is that we replace the missing progestin in the body, which ultimately is going to raise estrogen and progesterone levels. So we utilize progestins for contraceptives. For contraception, we can also give them for uterine bleeding. If patients having severe uterine bleeding, just because their menses is heavy, or even after surgery, we can do it for dysmenorrhea if they're having difficulty or painful menstruation. And we can also use it in conjunction with endometriosis treatment. So when patients are having pain while having endometriosis, we will prescribe progestins. Okay, so drugs that we utilize also to replace menopause relief is because there is low levels of estrogen that are causing all of these problems. We just replace the estrogen and we use it during menopause. So side effects of these estrogens are going to include weight gain and water retention. There may be some breast tenderness that goes along with it. You have to be exceptionally careful when replacing estrogen, especially in women that are 35 and older, because it does or can predispose them to developing thrombi and emboli, and especially if it runs in the family, but more so if you're in your 30s or 35 or higher. It can also cause an myocardial infarction. And examples of these medications are going to be your conjugated estrogens and your medroxyprogesterone that we give. All right, so when you're dealing with a patient that has menopause and is taking those replacement medications, they have to stop smoking, because during hormone replacement therapy, it's going to cause those vessels to kind of constrict, therefore raising blood pressure. Nicotine naturally causes vasoconstriction. So these patients have to stop smoking. If they are taking long trips, remember we discussed deep vein thrombus as well as pulmonary emboli. If they're going to take long trips, they should wear TED hose or compression stockings or compression devices. They've got to move and pump their legs quite frequently, especially if you're 35 or higher. If they develop any leg pain or heaviness in the leg, or warmth to the leg, shortness of breath, chest pain, that could be indicative of either DVT and or pulmonary embolism, they need to seek medical assistance immediately as soon as they start developing these symptoms. Okay, let's talk a little bit about contraception. It's in a similar vein as estrogen replacement. So the medication utilizes a combination of estrogen and progestin in order to stop and block ovulation. So when giving these medications in good doses, they're going to hinder ovulation. And the way that we hinder ovulation is to stop luteinizing hormone and follicle stimulating hormone. Because remember, we said luteinizing hormone is responsible for the maturation of those primary cells. Follicle stimulating is going to get the cell to release. So these medications are going to stop that from occurring. So we use these hormones for contraception. Adverse reactions can include high estrogen levels, high progesterone levels, high androgen levels that go along with it. So for hormonal contraception, make sure that you take the medication exactly as prescribed. If you miss a dose, always remember to take it as soon as you can. We always advise to make sure patients either have them by the bedside or in their purse, so that if you do forget, at least if you're out and about, you can take your medication as soon as possible. If you do miss several doses, you must use backup contraception and start all over again. You're going to have to start your meds all over again, okay?
Just to piggyback on that, you know, we've all heard all the ladies all over the land say, I was taking the pill and I got knocked up anyways, right? Most likely, they were not taking the medication exactly as prescribed. It is very specific. If you start taking your birth control pill at 9 a.m., then 9 a.m. every single day, you need to take that pill. It is intended to work that way. So if you take it at 10 a.m., then you're not taking it exactly as prescribed, and you could end up pregnant. I was terrible with the pill. Terrible. I might take it, I might not. Then I'll take 2 because I forgot one day, and then I forgot the next day. So I'll take 2, and then I'm sick as a dog because, you know, I took 2. Listen, if you just take it at the same time every day, exactly the same time every day, put a timer on the phone. This is what you teach your patients. Put a timer on your phone. Put 2 timers on your phone, but take it exactly at the same time every day. All right. Don't ever miss a dose. But if you do miss a dose, I think you can miss up to 2. You miss more than 2, then you're going to have to wait until the next time to start the next pack. All right. This has been my TED Talk.
Also, they can cause severe nausea, vomiting, and GI upset. It may be best to take them at bedtime. So that way, when the medication is working and you start having those side effects, it's okay, because once you start getting sick, you know, you'll be asleep. They too are hormones, which can cause the vasoconstriction, raising the blood pressure, so no smoking. And if you are pregnant, do not take them, okay? In high doses, it can abort the baby and then cause miscarriage and bleeding and things like that. So at the point that you find that you are indeed pregnant, you must stop hormonal contraception. Okay, for the gentlemen, we have androgens, which are hormone replacements as well, okay? And we use them for the development of secondary sex characteristics. So in patients that are maybe in their teens, for a gentleman, a young guy who's in his teens, and maybe you'll see it a lot of times, maybe in sickle cell patients or patients that lack growth hormone and they're not developing these secondary sex characteristics, we can start them on androgens so that they can begin to kind of grow and develop those secondary characteristics, which is, you know, the enlarged testes, enlarged penis, hair in the peri area, broadened shoulders, deepened voices, those things like that. So we use them for hypogonadism. So if the patient is not creating testosterone, then we'll go ahead and give it to them. If they are having problems with the pituitary glands, okay, that can ultimately do it. Especially if those pituitary glands are affecting growth hormone, like say in dwarfism, we can do it. We can also do it in eunuchism, where in eunuchism might be like a castrated person, or maybe they have an undescended testes. You know, usually undescended testes don't necessarily impact the level of testosterone, but if it does, then we can do that. And undescended testes is a cryptochyrodism, so we can utilize it there. If man has low levels of sperm, we can try it there. And if they just have low levels of testosterone, and sometimes that happens as men get older, they lose their libido, and that's ultimately because of testosterone decrease. So we'll go ahead and give it to them. So adverse effects of taking androgens, you might see some edema because it tends to retain sodium. And if it retains sodium, it's going to retain water. And if it retains water, we're going to see an increase in blood pressure. So you have to be careful with that. Because there are now high levels of testosterone in place, just like a teenage boy, you're going to have some acne. You're going to have some acne in these patients. You may have hirsutism, and hirsutism is just hair growing where you may not necessarily want it to, but for men, it to be okay. So that'll be like, mustache, beard. But if women take androgens, then they're going to see that too. So they may have the increases in hair, hair on the lips, hair on the chin, things like that, hair on the sides of their face. Now, not only does it cause hair growth, but it'll probably grow hair like, in the chin and the neck, the neck, the upper lip, arms and legs. But unfortunately, it can cause male pattern baldness, where they'll start losing the hair at the top of the head, but it'll grow everywhere else. Okay. Androgens can be damaging in high doses to the kidney, so you want to definitely make sure that you are looking for kidney problems. You want to look at, liver problems. You want to make sure you're looking for hepatitis or jaundice, looking at the sclera of the eyes, make sure it's not turning yellow, make sure the skin's not turning yellow, make sure they don't have that big abdomen for ascites. Those are things that you're going to look for. All right. Okay, I don't really care about the interactions. Make sure you take a look at them. But for nursing implications, report fluid retention. So if they start having a lot of edema on board, or their blood pressure starts to go up, they're looking fluffy, maybe coughing a lot, definitely they need to let you know. No tobacco, no smoking, okay, with any hormone medication, no tobacco, no smoking. And try not to let women handle these meds. Or children, okay? Do not let women handle these meds, or children. If they do have to handle them, glove up, okay? A little bit about osteoporosis. And in osteoporosis, you have the gradual loss of calcium in the bone. So the bones are going to be robbed of their calcium, and it's going to pour into the blood, causing hypercalcemia. This places people at an increased risk for developing pathological fractures, as well as it making it easier for them to develop, stress fractures. It can start as early as in their 40s. It can have a familial history where it may run in families for patients. And we use different classes. So we can use the biphosphates, we can use the androgen agonists, and then we can use osteoclast, monoclonal antibodies. So what happens a lot of times, estrogen has a propensity when it is in low doses to cause hypercalcemia, okay? It does cause hypercalcemia. So what happens is when you have those patients that are have low levels of estrogen that are forming in their body because, hey, they're going into menopause, it can also play a role in robbing the bones of their calcium. So let's talk a little bit about some of the drugs that we use. They prevent bones from losing calcium, and they increase that moving calcium from the blood back into the bone, therefore binding it to the matrices of the bones themselves. They also work to prevent osteoclasts from destroying bone cells. Remember, we talked about osteoblasts and osteoclasts. Osteoblasts are responsible for building up bone. Osteoclasts are responsible for destroying extra bone. So these medications are going to shut down those osteoclasts so that they can stop destroying bones. Because what happens is when it happens to destroy bones, it moves calcium from the bone itself into the blood. Side effects include, for these medications, are going to be headache. They can cause a lot of GERD or reflux and some nausea. And examples of them are aldrogenate and risonadronate. Those are the ones that you see most common. Alrighty. So for you as nurses, your implications, they should take them at first thing in the morning. Now, a lot of medications for osteoporosis are not going to be on a daily basis now. They have shifted over to monthly, even annual medications. But if they are taking the dailies, first thing in the morning, Also, anytime a patient takes medication, be it daily, weekly, monthly, or annually, they should remain upright or standing for 30 minutes after. And I mentioned that to you before we talked about musculoskeletal. They should remain upright for 30 minutes, okay? Shouldn't lay down because you want all of that good calcium to be reabsorbed into the bone itself. If they develop any chest pain, they need to notify you immediately because these levels, these lab levels, these medications rather are going to hopefully lower calcium level, and any imbalance in calcium level can cause cardiac issues. Because remember, we talked a little bit about calcium when we talked about calcium channel blockers, that calcium going in and out of cells helps to potentiate the contractility of the heart. All right, let's move on to diabetes. And when we're talking about diabetes, we're talking about diabetes mellitus, not insipidus.
We're moving over to chapter 17, just in case you're following in your book. Very good. Hey, you guys want to take a break? Been going for about an hour. Silence. Let's take a 10-minute break, guys. How long does this class last for? Okay. Yeah, let's take a break for about 10 minutes, okay? All right, everybody back signing into the chat? All right, everybody all signed in, back on camera, and we will, I don't think there's a million minutes left to go. I think we'll go through this, the diabetes, as the old guy from the oatmeal commercial closet, and we'll do our Zoom and be done, okay? Here we go. Everybody sign into the chat, don't forget.
But this has to do with ADH, diabetes mellitus, which has to do with insulin. Now, diabetes mellitus is a chronic disorder, and in diabetes mellitus, patients have high levels of glucose, circulating glucose. So that can be as a result of too much glucose, and usually also too little insulin. And it could be insulin, that's maybe they're not creating enough insulin, or that the body is still creating insulin, but unfortunately, there's something wrong with the insulin. It's kind of on the broken side. Okay, a little on the broken side, okay? So insulin is necessary for the metabolism and use of glucose in the body. So we need that insulin. Remember, it acts as a key for glucose. Glucose belongs in the cells, and the only way it can get in the cell is with an insulin molecule. If there is not enough insulin molecules, the glucose sits right on the outside of the cells, which is no good. On the inverse, we have hypoglycemia, where patients have low levels of glucose and they're lower than normal. You sometimes will see that in patients that are not taking their insulin, they're not taking their medications. So unfortunately, their glucose levels are going to increase. Now, remember yesterday we talked about the pancreas being the endocrine organ that is responsible for the creation of insulin. Remember, it uses those beta cells of islet cells. And also we talk a little bit about glucagon, and that helping to, in the event that they have hypoglycemia, it's going to work to create like concentrated glucose stores, so it'll help them. And then we talked about type 1 and type 2. Type 1 being that you normally are going to be born with it. Type 2, it usually will manifest as a result of lack of diet, lack of exercise, and age. All right, so we've talked about a bunch about these. Now, hyperglycemia is a little bit different than diabetes mellitus. Diabetes mellitus is the diagnosis itself. That means that, you've had several blood glucose levels that are high, and then you have the disease processes of diabetes mellitus type 1 or type 2. Hyperglycemia, on the other hand, is usually the state. So say, for example, you don't necessarily have to have the diagnosis of diabetes mellitus, but you can have a hyperglycemic state. So, for example, you're just a regular run-of-the-mill person, you eat a whole bunch of ice cream, and then at that time, your blood sugar is high until the glucose, until the insulin comes back in and sets it up, okay? And then we also have gestational diabetes, which normally only occurs while mom is pregnant, okay? And in gestational diabetes, at that point, mom is going to have a little bit difficulty regulating her insulin level because she has another person on board who is taking and absconding all of that glucose, all of those insulin levels. So it creates a gestational issue in her. Now, a lot of times with gestational diabetes, babies come out a little bit larger, birth weight babies, because they're taking up so much glucose from mom, and then ultimately causing mom issues. So sometimes you'll see them a little bit larger in size. Now, medications that we use, well, there's several. We're using when you try to fight diabetes mellitus, type 2. We're going to use diet and exercise first. If diet and exercise first doesn't work, then we'll go on to oral hypoglycemics. If oral hypoglycemics don't work, then we'll use insulins. So the oral hypoglycemics, the most common ones that we'll use are your sulfonylureas and your biguanides. So let's talk a little bit about those. Your sulfonylureas are going to stimulate the release of insulin in those pancreatic beta cells. Now, these are only going to work in type 2 diabetes because remember, type 1, they have no insulin. So you can't stimulate the release of insulin if there is none to be had. So these are only with our type 2 diabetics. They also help to decrease insulin resistance. So if you have these little stubborn insulins or stubborn, like say it's a key that's broken, I don't know, maybe the little teeth of them have fallen off. So what it'll do is it'll decrease that insulin resistance so it can adhere to the glucose molecule and then in turn move into the cell. So examples of them are going to be your glimepiride, your glipizide, and your glyburide. If you notice, they're all ides, and these are the medications that we utilize, okay? So once again, make sure you know those sulfonylureas are going to stimulate insulin release from those pancreatic cells, and they're also going to decrease insulin resistance for you. Okay, now we're going to do our nursing implications when taking these sulfonylureas, okay? So do not take with alcohol.
Hold on, pausing, guys. Did we need to slow this down any? Do I need to rewind or anything?
Could you rewind just a little bit, please?
Mm-hmm. Feel free to ask me to stop and pause or play again or whatever if you need me to, okay?
Once again, make sure you know those sulfonylureas are going to stimulate insulin release from those pancreatic cells, and they're also going to decrease insulin resistance for you. Okay, now we're going to do our nursing implications when taking these sulfonylureas, okay? So do not take with alcohol. Do not take with alcohol, okay? Do not take them at all with alcohol. Okay, sorry, do not take with alcohol. Make sure, especially with clopramide, no alcohol with there. You want to take them with or just before a meal. So by the time the meal gets digested, the medications will work within that 30 minutes to help potentiate the binding of insulin to those glucose cells, to those glucose molecules. Make sure you also watch for symptoms of hypoglycemia. So if they start being a little on the shaky side, or they start being a little, they're hungry, their thought process is a little off, make sure that they let you know, or a family member lets you know, the sulfonylurea may need to be tweaked a little bit. They also need to be monitoring their blood glucose, AC and HS, so before meals and at bedtime. And if they feel the need to do it a little more frequently, they most certainly can, especially when they're not feeling well, because when the body is immunocompromised, it has a tendency to increase blood glucose stores, so they may have to monitor it a little bit more frequently. If you have a patient that is NPO for several days, they should not be taking these. Normally in the hospital, if we have them NPO for several days, like say they're having a bowel resection, or they're having some kind of achalasia or dysphagia, something going on where they cannot swallow, and we have to put them on.
Hold on, guys. There's a question if we skipped a slide, so let me go and check. Let's see here.
It skipped the side effects slide.
Side effects. Let's see. All right. Hold up.
Hi, Cindy.
Share. All right. Here we are. Your side effects for those sulfonylureas or the insulin stimulators would be heartburn, nausea, vomiting, photosensitivity. Oh, excuse me. So if you go out into the sunlight, your patient may need some sunglasses to kind of protect their eyes. Weight gain is another side effect. Some adverse effects that that we don't want to happen. Your patient may get hypoglycemia, and those signs and symptoms of hypoglycemia are difficulty with concentrating. They may have tremors, rapid heart rate. They may be very anxious, and they may be very hungry. All right. If your patient is severely hypoglycemic, they may be non-responsive. Okay. All right.
That's scary.
It's very scary. I used to have a patient, one of my kiddos, he was like 12 or 13, and I don't remember which medication he was getting in the daytime. I don't know. I don't know what his daytime regimen was, but every night when I checked his blood sugar, he would be like 30 or 40. And so what I had did on my own accord to stop that from happening is every night when I would come in, I would give him an Ensure. So that when I checked his blood sugar at 9, it might have been a little bit elevated, but it was like, 90 to 100, and then he wouldn't drop during the night. So it's very scary to have a patient unresponsive if you have to give them, glucagon injections to bring them back to coherence. It's very scary. And that was when I was a brand new nurse, so I didn't know nothing. It took me a few days.
I mean, you knew something.
I know a little bit, but I ain't know nothing.
Yeah.
I was still wet behind the ears in my days of nursing at that time. So, but I knew I didn't want to see no more 30 blood sugars. I knew that part. All right. I think that's what we missed there. So we'll go back to that one. All right.
A feeding tube or some kind of
Go back
close to us, so they may have to monitor it a little bit more frequently. If you have a patient that is NPO for several days, they should not be taking these. Normally in the hospital, if we have them NPO for several days, like say they're having a bowel resection or they're having some kind of achalasia or dysphagia or something going on where they cannot swallow, and we have to put them on like a feeding tube or some kind of fluid for nutrition. Normally what we're going to do is we'll treat it with insulin, because having medications or oral hypoglycemics are a little too unstable in order for us to do that. So normally, like I said, we're going to be safe and just control it with insulin, because usually insulin has a short half-life. God forbid the blood sugar gets out of whack, we can either increase the fluids with, or we can give some glucose or anything like that to kind of control it. Okay. Now oops, am I skipping things? Okay. So I'm sorry, I skipped a little bit. Skipped a little bit there. So side effects for sulfonylureas are going to be heartburn, nausea and vomiting. They can develop some photosensitivity, so for that. Wide rim hats. They need to put on sunblock, sunglasses. You may see some weight gain. And if they are hypoglycemic, they may have some difficulty concentrating, tremors, increased heart rate. They're going to feel kind of funky, start talking out of their head, and they're going to be hungry. All right, let's talk a little bit about the biguanides. And the most common one you'll see given is metformin. And metformin is a relatively popular medication that we give to control blood glucose. And what it does is it reduces the amount of glucose in the liver itself, okay? It decreases and reduces the amount of glucose in the body itself. So even if they're eating, it's going to control it by lowering blood glucose. And we use this to treat diabetes mellitus type 2. We never use oral hypoglycemics in order to treat oral antidiabetics in type 1, only type 2s. So example is going to be metformin. So now side effects, they can cause a little bit of a GI upset. Sometimes they can cause lactic acidosis, and that's like rare scenarios, where they may be taking a little higher than 1,000 milligrams of it. You rarely will see it, but it does happen. So if lactic acidosis occurs, you may see some deep breathing, and what they're trying to do is blow off some of that CO2. They're trying to really blow some of that off. interactions, very important, are drug contrast, or medical contrast. So if they're having like a CT with contrast, or they're having, well, MRI, they wouldn't have a contrast. Well, CT more commonly. If they're getting dye contrast, or they're drinking dye contrast, unfortunately, it can cause kidney failure and shut the kidneys down. So normally, if they know that they're going to have a CT with contrast, or even if they have it without, because sometimes the doc may say, okay, hey, I can't see anything, let's go ahead and put it with contrast. We always want to ask them to hold their metformin for 48 hours prior, 48 hours after. So they may have to control their blood glucose with some insulin in the meantime, because it can shut down the kidney. So definitely, if you know that your patients are taking some metformin, and you know, hey, the doc is anticipating on having a CT with contrast, you gotta remind them, hey, doc, you know, hey, this patient's been on metformin, they just got here, they've been taking their metformin, we need to hold off on it, okay? Right. So there we go. We said stop taking the metformin 24 hours to 48 after. I'd even dare to say 48 and 48, but you know, you got to be careful with that. But I believe the book, and forgive me, the book probably says 24 hours prior and 48 hours after. So in the meantime, they're going to have to control their blood glucose with insulin in the meantime. They want to make sure that they are monitoring their blood glucose, and that goes with all anti-diabetic medications. No alcohol, because alcohol contains a lot of sugar. That's all it is. It's nothing but alcohol, right? It's nothing but grained alcohol. So definitely you want to watch. Look for signs and symptoms that go along with hyperglycemia, and you want to take it also with right before or with your meal. Okay, you want to take it with your meal. And last but not least, let's talk about insulin. Now, this section, ladies and gents, please pay attention to. This is exceptionally important. Insulin works to lower blood glucose by moving glucose into those target cells. So remember, insulin is the key that goes along with the glucose so that it can get into the cell. Now, we use insulin for type 1 diabetes exclusively. We can also use it for uncontrolled type 2. But remember, we always try to start with diet, exercise, then orals, then insulin if the need be. Okay, we can also use it for a disorder called diabetic ketoacidosis, or DKA. That's a medical emergency where patients are going to have blood glucose in excess of 500, 600. Okay, now normal glucose is 70 to 100, but you're looking at 600-700 blood glucose. And you will also, it's very indicative, because when patients have DKA, they start kind of acting a little weird, little goofy, little confused. If you smell the breath, it has a fruity smell.
She said normal glucose is what?
It's just very like a fruit, like a.
Say what?
What level did she say normal glucose was?
I don't know if she said
70
it here,
to
but
106.
yes, it's normally 70 to 106. If your patient's in DKA or diabetic ketoacidosis, they could be in excess of 500.
600, she said.
Got it. Thank you.
Old fruit. Think about like if somebody left
Hold on.
grapes
Let me
or
come back a little bit.
little confused. If you smell the breath, it has a fruity smell. It kind of smells like it's just very like a fruit, like an old fruit. Think about like if somebody left grapes or a peach around for several days, and it has like that wine smell. It's very acetone or fruity smelling. And they can also develop flushing. Okay. Now, when a patient has DKA, nothing else is going to work but insulin. Oral hypoglycemics are not going to work. We've got to hit them on insulin, and we got to give them an insulin drip. We don't even bother with sticking them. We just put it in the IV, take it to the head, and just automatically get it directly in. Okay? So symptoms of DKA, like I said, are acetone, like an acetone. They'll start spilling acetones into their urine. They'll start spilling ketones into their urine as well. They'll have a sweet breath, confused, and very flushed. And the only way to treat it is with plain regular insulin. Okay? So adverse reactions are going to be lipodystrophy, and lipodystrophy is found in what lipodystrophy is. It's like the hardening of one particular area from being injected so much. So if a patient constantly is sticking himself in the same location, that area is going to start getting a little bit hardened. So make sure they are rotating their sites. You may have some local itching at the area and some swelling and some redness. So that's why it's key for you as nurses to make sure that your patients understand how to administer those medications so that they don't develop the swelling, they don't develop the itching, and they don't develop the lipodystrophy. Okay. You may see some hypoglycemia, especially if they're taking too much insulin or they haven't eaten enough for that meal, and yet they still take the insulin. It's going to cause hypoglycemia. Okay. You have some drug interactions of taking with steroids and with alcohol, because remember we said alcohol is nothing but sugar, and it can, when you're taking it with insulin, can cause a hypoglycemic effect in those instances. So as nurses, symptoms of diabetes mellitus include the 3 Ps: polyuria, polyphagia, polydipsia. Polyuria is frequent urination. Polyphagia is frequent eating. Polydipsia is frequent drinking. Because what happens in a patient that has diabetes, just think about it like if you made a pitcher of Kool-Aid that is very, very sweet. In order for you to to mediate it and to control it, make it a little bit more pleasurable to drink, you've got to pour more water into it. So that's going to be you drinking a lot. Think about it like that. They have blood that's too sweet, and in order to get it unsweet, you drink more water, okay? Also, another way to get, if you had that sweet Kool-Aid, to get it unsweet, you may have to pour some of that out, right, before you put more water in. So you may want to urinate it off. Same thing here with those diabetics. They may have to pee all of that sugar off. And because you have high levels of sugar circulating, and remember, sugar is supposed to go into the cells to supply the body with blood, it desires more energy. So the patients are going to desire to eat a little bit more, okay? You may also see some blurred vision and some fatigue because it's causing that, and when you're having that assessment of diabetes mellitus. Okay. All right. That's all I wanted to say on there. So now let's talk a little bit about how we take care of insulin. Okay. Insulin should be stored at room temperature once it's open. But before it's open, you want to put it in the refrigerator. So keep it in the refrigerator until you're ready to use it. And usually you want to store it at room temperature once open. Once open, it's okay to store at room temperature. Okay. I know it used to be we put insulin in the refrigerator, and a lot of hospitals, we do still put it in the refrigerator, but for the most part, it does not have to be in the refrigerator. Okay. You want to discard any regular insulin that appears cloudy. Regular insulin is short acting, and it should always be clear, clear, clear. It should not be cloudy at all. Okay. Also, insulin should peak when the meal is started. So that's why it's very important. And I'm going to show you, I think in the next slide or two, the different peaks and durations of these medications. You have to know that slide, guys. You got to know it. You got to know it. You got to know it. So if you know that your insulin is going to peak in 30 minutes, then you want to, or it's going to peak in 30 minutes, and food is at 8:30, then you need to give it at 8, right? Because they're going to start eating at 8:30, and you want it to peak so that it offsets those high levels of glucose that are about ready to come in as they're eating. So when giving insulin, prior to giving it, always inspect it for contaminants, okay? If it's cloudy and it looks funky, especially regular insulin, get rid of it. In order to shake it, or even if you have to warm it, roll it between your hands. Do not shake it. So you're just going to roll it in between your hands like you're rolling a piece of dough, okay? You want to draw up the air that you need, okay? You want to draw up the amount that you need. So anytime we're mixing insulins, and you can mix insulins, if you're ever unsure, just give them separately, okay? So the way that we draw up insulin is we're going to draw up, let me start from the beginning, I'm sorry. Let's say that we have a patient that has to have long-acting and regular insulin. Long-acting is not going to kick in until, a few hours later. Short-acting is going to be right with their meal, and you can give them together, okay? With the exception of Lantus, that's the only long-acting insulin we cannot mix. So the first thing, let's say you have them side by side. You have long and you have short, okay? And let's say we have to give 5 of long and 2 of short. The first thing you're going to do is you're going to inject air into your long. So you're going to pull your plunger bag up to 5 units. You're going to insert the needle into the vial and push the air in. Okay. Then you're going to take the needle out. Now what you need to do is now pull up 2 units of insulin, and now we're going into the short acting. So we're going to inject it into the short acting vial, push the air in, and then turn the vial upside down and draw up your 2 units, okay? Once you've drawn up your 2 units, now we need to pull up the 5 units for the long. So we're now going to inject the insulin into the long, inject the needle, not the insulin. Inject the needle into the long, turn it upside down, and draw it up. Okay. Now, the reason that we do it in that manner is, let's pretend that we have long and we have short acting. Okay. You never want to mix long acting with short acting. That being, if we have long acting medication and short acting medication, acting medication normally acts in 30 minutes, right? Long acting can take almost up to 12 hours to start working. So let's say I'm the first nurse, right? And I come in and my patient takes long and short insulin. And let's say that I accidentally mix short acting into long acting. I do it inverse. I don't do it correct. And it's just a little bit of short acting that gets mixed into that long acting. And then one of you guys comes behind me, and your patient only happens to take, for example, long acting. You know, they don't necessarily have to take all of those medications. So I'm accidentally mixing the long acting into the short. So I'm sorry. Let's say that they take long acting. You come behind me and you draw up that short acting insulin and you give it to the patient. Now you're expecting to see a reaction within 30 minutes. But if there is a little bit of long acting that's mixed in the short acting, in 12 hours, they may start manifesting some hypoglycemic actions because they weren't supposed to be getting any long acting. But if the short is mixed into the long, not a problem. But if the long is mixed into the short, that does become a problem. Okay.
That makes sense to everybody? I know it can be kind of confusing dealing with insulins and things. Miss Talisa shaking her head.
Can
Is that a
somebody
no?
just repeat?
You want me to?
I think I got it. She confused me. But I think the gist of it was, don't mix long into short, but you can mix short into long.
So you can mix. So your long acting is like, and she'll go over this in the next slide. So your long acting is like Lantus. It's a very long acting insulin, type of insulin rather. And what you don't want to do is get that into your regular insulin, your short acting insulin, because if you do, then you're not expecting your patient's blood sugar to drop, 8 hours later. Does that make sense? So if you get that long acting into that regular insulin that's supposed to be short acting, then so many hours later, your patient's blood sugar is going to drop significantly and you're going to be trying to figure out what happened. Right? But if we get some of the regular insulin into, let's just say, your NPH or your intermediate acting or your long acting, like we're not really going to be as concerned because, well, we mix together that intermediate and the regular anyway, right? Does that make more sense? I'll rewind it again.
So when giving
Is
insulin,
somebody
prior to
vacuuming?
giving it always.
Say what?
I said somebody vacuuming.
Oh, I can assure you it's not me. I need a vacuum. All right.
Is inspected for contaminants, okay? If it's cloudy and it looks funky, especially regular insulin, get rid of it. In order to shake it, or even if you have to warm it, roll it between your hands. Do not shake it. So you're just going to roll it in between your hands like you're rolling a piece of dough, okay? You want to draw up the air that you need, okay? You want to draw up the amount that you need. So anytime we're mixing insulins, and you can mix insulins, if you're ever unsure, just give them separately, okay? So the way that we draw up insulin is we're going to draw up. Let me start from again. I'm sorry. Let's say that we have a patient that has to have long acting and regular insulin. Long acting is not going to kick in until, a few hours later. Short acting is going to be right with their meal, and you can give them together, okay? With the exception of Lantus, that's the only insulin, long-acting insulin we cannot mix. So the first thing, let's say you have them side by side. You have long and you have short, okay? And let's say we have to give 5 of long and 2 of short. The first thing you're going to do is you're going to inject air into your long. So you're going to pull your plunger back up to 5 units. You're going to insert the needle into the vial and push the air in. Okay, then you're going to take the needle out. Now what you need to do is now pull up 2 units of insulin, and now we're going into the short acting. So we're going to inject it into the short acting vial, push the air in, and then turn the vial upside down and draw up your 2 units. Okay, once you've drawn up your 2 units, now we need to pull up the 5 units for the long. So we're now going to inject the insulin into the long, inject the needle, not the insulin. Inject the needle into the long, turn it upside down, and draw it up. Okay? Now, the reason that we do it in that manner is, let's pretend that we have long and we have short acting. Okay? You never want to mix long acting with short acting. That being, if we have long-acting medication and short-acting medication, short-acting medication normally acts in 30 minutes, right? Long-acting can take almost up to 12 hours to start working. So let's say I'm the first nurse, right? And I come in and my patient takes long and short insulin. And let's say that I accidentally mix short acting into long acting. I do it inverse. I don't do it correct. And it's just a little bit of short acting that gets mixed into that long acting. And then one of you guys comes behind me, and your patient only happens to take, for example, long acting. You know, they don't necessarily have to take all of those medications. So I'm accidentally mixing the long acting into the short. So I'm sorry. Let's say that they take long acting. You come behind me and you draw up that short acting insulin and you give it to the patient. Now you're expecting to see a reaction within 30 minutes. But if there is a little bit of long acting that's mixed in the short acting, in 12 hours, they may start manifesting some hypoglycemic actions because they weren't supposed to be getting any long acting. But if the short is mixed into the long, not a problem. But if the long is mixed into the short, that does become a problem. Okay? All righty. So these are the different types of insulins. Please put a star, highlight, whatever you need to do for this slide. Very, very important. Regular insulins can be rapid or short. They are usually going to work 15 to 30 minutes before breakfast. Okay, so having known that, you know when to give it. So rapid acting is usually going to be your 15-minute. Those are the quick and dirties. They, for the most part, end in the logs. Those are your Novalogs and your Humalogs. They will start working in 15 minutes, but they will peak in 30. So if you know that breakfast is at 8:30, you better give that insulin at 8 o'clock so that it peaks right when they're eating their breakfast. And usually it's only going to last a couple of hours. So make sure you know this slide very well, okay? Then we have our short acting, which are our LINs, our Novolin and our Humulin, where they're going to start working within a half hour to an hour and a half. And they're going to peak within two hours or so, right? So you can utilize both, but most times the docs are going to have Novolog in the facilities. We also have intermediate acting insulin, or NPH, and it starts working within 1 to 4 hours, and it's going to peak within 4 to 12 hours. And then we have our long-lasting. Now, our long-lasting normally can be mixed with the exception of Lantus. We never, ever, ever mix Lantus. So to be on the safe side, I would always suggest if you ever have a question about how to draw short and long up or intermediate up, just stick them 2 times. I mean, I know they hate to get stuck, but if they're diabetic, they're accustomed to getting stuck and the needles are small. So just to be on the safe side, pull them up separately, okay? But you can. I don't want you to think that it cannot be done to be mixed. The only one you cannot mix is Lantus. No way, no how. No Lantus, okay? So know that you normally are going to give Lantus, Detamir, and Levemir at bedtime. They start working within 2 to 3 hours and peak at about 6 hours, with the exception of Lantus. Lantus does not have a peak. The way that Lantus works is that it's going to go up at 2 and it stays up. So it really doesn't have a peak. So in other words, usually with a peak, you're going to have an up and a down. Lantus remains up. So there is no peak with Lantus. Also, when you're giving these long-acting insulins, know that they begin to, with the exception of Lantus, they begin to kind of start going down about after 8 hours or so. So it's always best to try to make sure that your patient has a nice midnight snack, so that not midnight, but before bed snack, so that as that medication begins to start going down, they will at least have some glucose, some circulating glucose in their body system. Okay, so that's it. That concludes this lecture, recorded lecture. Make sure you know this slide to its entirety, and that's going to be very, very beneficial when you study. Also, please make sure that you are reviewing everything that I've said kind of multiple times for you, and do be sure to make sure you're reading your book and answering any ATI practice questions. Okay, guys, thank you so much. Have a great day.
All right. Any questions on the lecture today? I'm going to take that as a no. All right. In that case, guess what time it is? Marinate on all that you learned today. Marinate on it, sit on it for just a minute whilst I get your game ready to play. All right, here we go. I switched it up for today. You're welcome. We have reggae music for today. Oh, I didn't give you a name. Hold on. Just pick whatever name you want. It's a good sound, right?
What's the name?
Whatever you want.
Okay.
Merry Crema. Love it. Over it. All right. 3 more weeks to go. I mean, they're really breaking it down. Waiting on everybody to get in there. Here's the pause in. I mean, whoever's playing this organ is doing a great job. Come on, everybody. We only got 7 players. All right, I'm gonna give a couple more minutes and then we'll get started. People changing it. Deep sigh. Bless it. game. Get in there. All right, you ready to start? All right, here we go. Most commonly treated with insulin is what? Diabetes type 1 or diabetes type 2? Very good. Remember we said there are people with diabetes type 1, they do not make their own insulin at all. So we have to give them exogenous insulin, which means we have to give them injections, right? Diabetes type 2 said we're going to try our best to treat it with diet, exercise, oral medications next, and then the last thing that we're going to try is insulin. So most commonly, we're going to treat diabetes type 1 with insulin. All right. Oh, over it. You're not too over it. You number 1 right now. Short-acting insulin is which one? All right. Remember she said on that last slide, get that slide, tape it to your pillow, hang it on your fridge, put it in your car. Don't look at it while you're driving, but put it on your phone. Remember it, remember it, remember it. That's very important. You're going to see it from now until the end of eternity when you become a nurse. All right. So remember all of these different types of insulins. All right. Oh, Power Frog 75 is coming through. Long-acting insulin is which one? Look at you guys. I'm so proud. Everybody picked the right answer. So proud. Strong work, team. Strong work. All right. Which one is an intermediate acting insulin? Very good. Dextrose is not insulin at all. Lantus is the long-acting one. Remember, we said we're going to give that one at night, and it's going to sustain them throughout the night. Novolin is your regular insulin. It's short-acting. And then, so your intermediate is the mix of the regular and intermediate. All right, so Humalog 7030 is your correct answer. All right. Which of the following is not a result of testosterone therapy? Yay, good job, guys. Remember said when you're taking the testosterone, if we're giving it to the fellas, or the ladies, they're going to have increased hair growth. Remember, they may have hair pop up anywhere. Fun fact, guys, I'm not trying to be mean at all. I kind of am, but not really. So my brother has a wife, and I call her the bearded lady. I don't think she takes any medication, but she thinks she's real cute. And so don't laugh, guys, but I call her Auntie sometimes. You know, like pray for me. You're welcome. You can use that term if you want to, but be nice to people. But Auntie is what I call her. Anyway, just moving on. So we said that increased hair growth is one of the side effects. You can remember that for a test if you need to. Just remember Auntie, okay? It'll help you remember. But they're going to have fat distributed other places. They're going to get a deeper voice, but their pigment is not going to change if they're taking testosterone, okay? You're welcome. I try to make y'all laugh anytime I can. What may low levels of thyroid hormones cause? Low levels of thyroid hormones. Good job. Remember, if you don't have enough of the thyroid hormones, that's going to cause hypothyroidism, and it's going to slow everything down. So it has nothing to do with puberty, for one. So great job for nobody answering that one. But it will cause you to gain weight. Everything's going to slow down. So if you have hyperthyroidism, you're going to lose weight despite eating, and you're going to be very hyperactive. All right? Good job, guys. Power Frog is holding strong. All right. Patient teaching for a patient is taking alendronate. Good job. Very good. So most of you either said remain upright or take in the evening. Remember, with this medication, you most likely want to give it in the morning, right? But absolutely 100%, please remain upright for 30 minutes after, because it can give you GI upset. Strong work. Power Frog still holding strong. Minnie, you're coming up. You're coming up. Y'all are so close. Hormonal methods of contraception contain which hormones? Very good. Remember, testosterone, we don't usually put that or ever put that into birth control or any sort of contraception. So that is not correct for that reason. But progesterone and estrogen, remember, those are the two that we use for hormonal contraception, right? And the other two are just plain wrong. Very good. Oh, Minnie got you, Power Frog 75. You got to come on back up. All right. Which of the following patients should be advised against hormonal contraception? Good. Very good. So the reason behind this is, okay, nobody picked the woman with asthma. This non-smoking woman who is 35, she's an excellent person who should be taking hormonal contraception, right? I mean, 35, she doesn't smoke. She's a great candidate for it. The woman with a history of anemia due to heavy periods, she should take some hormonal contraception because that could help her heavy periods get a little bit lighter and would help the anemic problem. But any woman who has diabetes, as the guy on the oatmeal box says, with any vascular complications should be advised against, because remember, if you're taking hormonal contraception, it can predispose you to getting blood clots. And if you already have vascular problems, then it can make it worse, and we could be into an emergent situation, all right? Very good. Oh, Flower, come on up. Look at that. Look at that. Okay, one more. Which of the following adverse effects is specific to the biguanide diabetic drug metformin? Remember we said, it's close to the end, I'm sure everybody was getting sick of listening to all the things, but lactic acidosis is one of the things that can happen when you're taking metformin, especially when you're taking it in excess of 1,000 milligrams. All right, so metformin is a drug that we're giving to control hyperglycemia. It's not necessarily going to give you a hypoglycemic episode unless you're taking it and you've been in PO. It can be a side effect, not necessarily an adverse effect, which is the same for the GI distress, not an adverse effect, more of a side effect. But lactic acidosis is serious. So that is our adverse effect for that one. All right, good job, guys. Let's see who won. Coming up to the podium. Number 3, 75. Woohoo! Minnie is number 2. And number 1 is and number 5 is 5. Who is Flower? Hold up.
Me.
Yeah.
I'm Flower.
Yay, Miss Chubb is Flower. Hold up, I gotta stop this music. That's enough. Let's take that off. Okay. Now, where was I? Who was Minnie? Yay, Miss White. And who was Power Frog 75?
Me.
Yay, Miss Nakia. This is great. You guys did a great job. Everybody else did pretty good too, so we're all winners in that aspect, right? However, because there is a number 1, I'll give you 2 points on your next, what class is this? I don't even know. Pharmacology exam. 2 points.
Yay.
Let me write this down. So that's on exam number 4, okay? If I forget, please remind me. Very good. All right, does anyone have any questions over what we covered today? Very good. This lecture is posted both in Canvas and I think the link goes straight to YouTube. So if you want to go back and review, go over it with your notes, feel free to go there and look it over. If you have any questions over it, write them down for me, send them to me, and I will try my best to answer it for you. Just give me a little bit of time so I can research it if I need to, okay? Other than that, I thank you for your time today. And I will see you, not tomorrow. I will see you in person on Thursday. Guys, please remember the dress code that is on your syllabus. Please be 100% in dress code when you come to campus on Thursday, okay? Very good. We'll have a great day and I will see y'all on Thursday.